Esophagus is 4 to 6 millimeters and duodenum is 6 to 8 millimeters. In this picture, we have done through the stomach, and that's why we are dilating it more, because the intent was to place plastic stent. And this is 15 millimeter balloon, which is being insufflated with contrast and saline. You can actually see under EUS view nicely. So that tells that the position is accurate and the diameter achieved is also what you want to. The next step is now, after dilation, is to place stents. So these are the other methods of a different caliber of balloon that which we were just mentioning to. If the intent is to place a metal stent, that is a cold stent, I'm sure my other learned colleagues will speak about the hot stent, the hot Spaxus, but with the cold stent, we need to dilate a little bit, because to allow the assembly to go in, assembly of the stent is 10.5 French, about 3.3 millimeters, little more than that. So we need to be a little dial more than that. So 4 to 6 millimeter balloon is good enough. And as you can see it here, this is a 6 millimeter balloon, a stiff balloon, after the initial creation of fistula. The next step which has to be quickly done is place the stent. So if the plastic stent has to be placed, we place up front at least 2 guide wires. Several access devices are available. A double lumen cannula or a large bore dilated cannula can be used, through which 2 guide wires can go in, and then you place stent one by one parallel to each other. But if the intent is to place the large caliber metal stent, here for example is Nagi stent, so we pass the cystotome, dilate with a balloon after the initial steps remaining the same. So the final step, instead of using 2 guide wires, here a small caliber balloon is being used, and then we place the Nagi stent. And visualization of the Nagi stent is done both using EUS as well as fluoroscopy, and the last part is done under endoscopic view. This is the last part being done. The equivalent endoscopy, the fluoroscopy view is separate. And that's how the stent is placed. So the final position of the stent would look something like this, a little bit projecting out into the gastric lumen, about 1 centimeter or so. The stent is about 2 centimeter to 3 centimeter long. If the waist is right in the center of the stent, around center of the length of the stent, then that's a perfect position. The risk of migration is minimal. If the thinnermost point is skewed to one side, then stent can migrate. And that's what is an important caution when you place these stents. Occasionally we can see this bow tie appearance, which Jong very often wears in parties, which we used to attend together. And this bow tie can sometimes be seen on the EUS imaging. So coming to these large caliber metal stents, the family of these stents, there are several of them now. They are divided into lumen opposing metal stent, and the commonest in the subgroup is Axio stent and Spaxus stent. The word lumen opposing tells us that they have a good ability to hold both the target organs together, that is stomach and the cyst cavity. The Bi-Flange stent, as the name suggests, are also biflange, but their lumen opposing capabilities are much lesser. They are a little longer. This is 2 centimeter to 3 centimeters long compared to 1 centimeter in Spaxus and Axios. Spaxus actually tends to infold on itself, so it actually becomes about half a centimeter long. Plus, these stents are very soft. They give an added advantage. A soft stent does not cause too much harm. It won't cause any bleeding from the vessels inside, whereas others sometimes can cause if they're stuck well to the wall. So we have pluses and minuses of each sub-variety of the large caliber metal stents. We can discuss it later. And this is one of our publication earlier, which we had of using Nagi stent, a step-up approach using dedicated Bi-Flange metal stent, that is Nagi stent. It reduces the need for direct necrosectomy in walled off necrosis. Let me elaborate on this. In this study, we placed a Nagi stent in all patients who are coming for walled off necrosis for drainage purpose. And just placing the stent itself improved them in 3/4 of the group. But 1/4 did have some problems after the stent was placed, which was in the form of pain or fever or infection. and they needed some more interventions through this cavity. And as we increased our intention of intervening in them, which could be in the form of incremental, we were using declogging of the stent or placing a nasocystic tube to irrigate, and the final step was direct endoscopic necrosectomy. So let me show what happens, and with each of these steps, we kept accumulating the success rate, which reached almost to 96.5%. This is a very important slide. I would like all the audience to look into it. Which are the different imagings that we use at different points of time when we place these stents? When we inspect the cyst, it is pure EUS. When we puncture the cyst, it's pure EUS. We don't require fluoroscopy and endoscopy. When we pass a guide wire, obviously we need EUS, and fluoroscopy can tell us how many loops we have made. When we create a fistula by using a 6 French cystotome over the guide wire, EUS is compulsory, so that's why we need to keep the guide wire in view. Fluoroscopy may help, but it's not essential. The next step of balloon dilatation, obviously EUS is important. Fluoroscopy and endoscopy, if you're using contrast, fluoroscopy is useful, but endoscopy also will help us to know whether you are right in the position. And then final placement of stent. Again, EUS is important to place the inner end of the stent, especially if using a metal stent. But fluoroscopy is also important to use to show that the inner end of the stent has reached inside. And for the outer end, that is the gastric side of the stent, endoscopy is important along with fluoroscopy. So these are different steps where these imaging would be useful. So trimodal imaging, use selectively and judiciously where to focus. The next advancement which occurred with the Nagi stent is it became hot, just like other stents which are available like Axios, and the same the cautery enhancement was done with a different mechanism. And this is with freehand technique, you can burn your way now inside the cyst. So when you do this, the last step remains the same, that is deploying the stent, but the first 3 steps of puncturing, passing the guide wire, and dilating and creating a fistula or with a balloon can all now be taken care, can all be avoided. So you just go directly to the 4th step. So this helps in improving the efficiency of drainage. Occasionally, if the wall is very thick, then we need to probably puncture with a needle, and then over the guide wire we burn our way in. But as the technology is evolving, so is the ease of placing these cautery enhanced Nagi stent or Spaxus stent. And all these stents are very efficient. In no time, the fluid drains out, and so does the solid loose debris. The interventions that are required at later date can be declogging of the stent, as I mentioned earlier. As you see, the stent is clogged by a loose debris, which can be teased out using a snare or any other forceps device which can pull it out. If the debris is adherent and not coming out easily, there's no point wasting your time, and for direct endoscopic necrosectomy, we can place a nasocystic tube and irrigate with just plain saline 100 ml 8th hourly, and occasionally we use hydrogen peroxide if it is infected or very tightly adherent to the back wall of the cyst. The last step is direct endoscopic necrosectomy, which is a very labor-intensive procedure. It takes time, it is fraught with danger. Several complications have been reported with this, and this should be avoided as far as possible unless it's paramount. And in this patient, as you can see, we are passing, pus is coming out, debris inside, we can visualize it. We can take the scope through the stent inside the cyst cavity and pull it out. I'll show some more examples of necrosectomy in this video. So the advantage of these large caliber metal stents, especially I'm talking about Nagi stent now, it's easy to deploy, high technical success, less like any other large caliber metal stents. They have large diameter up to 16 millimeter, causing very efficient drainage. They are fully covered, so prevent any leaks and perforations. They are self-expandable and sometimes can prevent an entry site bleed. I'll show an example of that. And since they have a bi-flange or a saddle-shaped design, risk of spontaneous migration is very rare. And re-intervention, if required, can be done through all of these stents. But there are some disadvantage also associated with these stents. For example, malpositions can occur in spite of the best hand with the operator, these things are known, especially in cysts which are very large in size or they're very small in size. The medium size are the best to start off for the beginners. Bleedings can occur not only from the entry point but also from the far away wall. And as the cyst collapses, the far wall comes towards the stent and that rubs against the inner wall or the inner flange of the stent, and that can cause bleeding. Migrations do happen spontaneously as a cyst collapses, it can expel it out, which is a good thing to happen. But sometimes, if the stent is not nicely placed, that means half is not inside and half is not outside, then it can migrate in either direction. Or it can happen during direct endoscopy necrosectomy. And sometimes they are hindrance to the direct endoscopic necrosectomy. What I mean to say, if a large chunk of tissue is there sitting around the inner flange, you cannot go take a scope inside and catch it. So you probably have to remove the stent, or it may come out with the debris, and then you can do the complete cleaning. So which stent to be used, plastic or metal, always remains a debate. But my personal take is that pure pseudocyst, that is, there's hardly any debris or debris is less than 10%, plastic stent probably is as good as a metal stent. But those collections or wands which have more than 30% debris, metal is always preferred. Between 10 to 30% of debris, which is still debatable, and it can be either way. Or collections which have only fluid but they are very large in size, metal is generally preferred. These stents have to be removed timely. As you can see, this patient came much later. Normally we remove by 3 to 4 weeks, but if they come late, sometimes the stent can migrate inside, although they can still be removed. As you can see the stent peeping out. So before removal, we often do an MRCP, which tells us the ductal anatomy, and based on that, we can take a decision of doing an ERCP and bridging of a leak or a disconnected duct, which appears like a stricture, can also be taken care of if you can pass the guide wire across. Let me show you some special situations where these stents come into use. This is our Nagi stent which has been clogged by a debris, and it is using a snare, a braided snare. This is a preferred instrument to remove this debris, and this is a very large chunk. And when it comes out, because the stent does not have too much of a lumen opposing capability, even the stent can migrate out. One should not worry that the stent has come out into the stomach. As you can see it here, that the debris is out, but the stent is also out. Pus is coming out into the stomach. The stent is in the stomach now. So you can actually remove this stent like a foreign body. Clean it up and let's keep it ready. We can reuse the same stent in the same patient. I will show you how we do it. So while the cleaning is going on, you can actually now go inside the cavity through the same opening and clean it up further. You can further continue the necrosectomy if desired. You can see big vessels inside. So this stent which has come out now can be loaded in a forward wing endoscope, which is also used for necrosectomy. So how we do it? Replacing the externally migrated Nagi stent, you catch the loop, the knot of the loop with a foreign body forceps, which is passed through a forward wing endoscope, regular endoscope, and then squeeze your way in by twisting mechanism inside the stent. Once the stent is loaded inside the working channel of the endoscope, you can take this loaded endoscope with the stent directly inside the cavity and gently push out this foreign body forceps while withdrawing the scope. As you can see it here, the stent is back in its original position, and you can continue if you want to do necrosectomy or just leave it off. So the only requirement is a regular upper GI endoscope and a foreign body forceps. Another example of migrated internal stent. This was a patient who had a large collection, and we could not see it endoscopically how we were placing it, and the stent dropped inside the cavity, and you can see it here. So the stent is in the lower part of the, we realized it soon at the time of placement. So we place another stent, a cystogastric stent. And if I can show you this video, so what we did when to salvage this internal stent, I'll just, so you went inside through the stent, cystogastric stent, and deep inside the cavity, as you see on the CT scan image, is lying this stent. It's very far away, and then you pull it out. This was the index drainage. You can see the guide wire from the stomach going all the way to the pelvis. This was the extent of the drainage. And at the time of removal, this is the stent, cystogastric stent, through which we are going inside to catch the internally migrated Nagi stent. And by pulling it out, the stent gets squeezed and comes out. So all these permutation and combinations are possible, but never lose your cool. I'm sure all position or situations can be salvaged. Occasionally, a stent does migrate at the time of placement and it comes later on with an internally migrated stent. The previous one happened soon at the time of placement. We realized it, but this was much later. Fortunately, we had a small stoma which could be visible. So we dilated this stoma with a balloon, as you saw, and then take the foreign body forceps, catch the edge of the stent, and gently tease it out and reposition it. So that's how it happens. Another example is the entry site bleed. This was a patient with minimal debris, as you can see, and the intent was to place plastic stent. But during that, we realized that patient is bleeding heavily inside the cyst from the entry point. So we changed our strategy. You can see the Doppler almost throwing blood. And then we changed from plastic to a metal stent. We decided not to place plastic and just converted to a metal stent. And any metal stent will cause a tamponade. This was a Nagi stent which stopped the bleeding, as you can see in the lumen. So patient did not require any transfusion, angiography, or a further CT scan. He was stable soon after. So the complication that can occur with EUS guided drainage of pancreatic fluid collections is bleeding, perforation, infection, and air embolism. Air embolism has almost gone away because of the use of carbon dioxide. Infections do happen, and that's why we re-intervene. Perforations have also reduced with fully covered stent, and bleeding can be tackled, especially if it's entry site bleed, by using a fully covered stent. In the end, I would like to conclude by saying that metal stents, all these dedicated large caliber metal stent, Nagi and so on, can be used for one with significant debris. Plastic stents, as I said, is used for pseudocysts or those with minimal debris. Remove these large caliber metal stents after finite indwell time, that is not more than 4 weeks, generally between 3 and 4, and re-intervene only based on symptoms of the patient. I would like to introduce our team at AIG. We have a large team who are, each one is better than the other one. And this has been our statistics over last 13 years or so. The numbers kept rising except for the COVID year. And I would like to share that we just completed 1,000 Nagi stent placement this month. And this has been our journey from 2013 to now. We have been placing almost one stent every third day, if you can say, of Nagi stent. This is not including plastic stent. It's pure Nagi stent. Thank you very much for your kind attention. John, you're mute. I can't hear you.
Hello, can you hear me?
Yes, John.
Okay. Sandeep, was very nice presentation. Very fantastic, as always. So you are using 2 stents. When do you use Nagi or Spaxus or Axios for peripancreatic fluid collection? Is there any special indications for each stent?
So Axios, we are using less because of the cost constraints. Although it's a very efficient stent, we all know that. Spaxus stent, we prefer in patients who have very large amount of debris. If we are forced to drain, say a collection which has more than 30 or 50% debris, then we consider Spaxus. But we also use mainly for gallbladder or GJ, where lumen opposing capabilities are much more. But my comfort level has been there with Nagi, and that's what we have been. Nagi as a person and Nagi as a stent.
You are good junior doctor of Nagi. So another questions from the attendants. When or how do you decide to removal of limbs for the one patient?
So these metal stents we remove after about 3 to 4 weeks. Patients are admitted for drainage, and once it is done and they are stable, so second or third day after procedure, they go home. Unless they have fever or pain, which is new onset or persistent, and then we investigate them by doing a CT scan. But those who are stable go home. And they come back about 3 weeks later. At that time, we get an MRCP done, which tells us two things. One is the resolution of the collection and also the ductal anatomy. We almost always place, I forgot to speak in my talk about placing a double pigtail plastic stent through these metal stents. And if there is any residual cyst cavity and the patient has disconnected duct, then we gently tease out only the metal stent, leaving the plastic stent inside. So always remove the metal stent, but if it has a plastic stent, we make an effort to remove only the metal, leaving the plastic stent inside, especially in a situation if he has a disconnected pancreatic duct.
Very nice. You recently you published a very nice paper about that on gut. Congratulations. Another questions, what do you do if stent is migrated into the cyst or on the stomach during deployment?
Okay, so if it deploys in the stomach and I realize at the time of procedure that this has happened and my guide wire is inside the cyst, I do not worry. I will place a nasocystic tube leaving the stent inside the cavity, inside the stomach, and drain him off. A few days later, once his collection is gone away, then I come back and dilate that path, place a plastic stent and remove this metal stent. Or alternatively, the same session, I can place one more metal stent with my guide wire inside and then pull out the stent which is migrated in the stomach. But that means I lose two stents. Second situation is when the stent has migrated inside the cyst cavity, which is much, much more common. And I would tell the viewers not to get worried. If that happens and you realize that you have the guide wire, which is your lifeline, and with using this lifeline, you can place either one more stent, or you can just place plastic, or you can place two guide wires using the first guide wire as your guide, and place plastic and a nasocystic tube. So anything to drain is important. Do not leave the drainage and come back next day. Complete the drainage part of it. The metal stent which is migrated inside can be removed a few days later when the cyst anastomosis is mature enough to pull it out.
Thank you. It can be the last question for you. So you are very expert about step-up approach. Could you explain more detail about your step-up approach to the beginner?
So in step-up approach, we have three major different steps. The first step that we prefer is declogging the stent. What is declogging? When the debris is loose inside the cyst cavity, after placing a Nagi stent, all the fluid will come out easily. The solid part may come inside and block the lumen of the stent if the size is mismatched. That means that the debris is bigger than the stent lumen. And that may cause symptoms in the patient. So if he has symptoms, we do an endoscopy second day or third day, and we find this, we pull this debris out using a snare or a tripod or a forceps. Once the stent is clean now, we can leave him like that, and that usually does not require a second intervention. If we see the patient has symptoms and the debris is quite adherent to the back wall by peeping inside the cyst cavity, we then place a nasocystic tube for irrigation. The tube goes inside through the nose, through the esophagus, through the stent into the cyst cavity, and we irrigate with a only saline 100 ml 8 hourly as bolus. Every third day we do an endoscopy and check. If the cyst has become loose, then we try to grab it with a snare or instruments, other instruments, and remove that. But if it's still firm and adherent, we try not to be very aggressive at necrosectomy, because below the cyst are splenic vessels which are large and sometimes can accidentally bleed, and that can be torrential. The last step of this step-up approach is direct endoscopic necrosectomy, as the name suggests, which means you actually physically go inside and catch the debris and pull it out. This is a long drawn procedure, can easily take half an hour to 1 hour, depending on the quantity of the content, is fraught with complications, should be done only when it's nothing else is possible.
Very nice. I totally agree with your opinion. Okay, Sandeep, thank you. And if possible, please stay on our webinar to make some discussions in the end of our all speeches. Thank you. And I would like to introduce the next speaker, Pradam Chai from Bangkok of Thailand.
Hi.
He's our good and very nice friend and great teacher of the interventional US around his country. He's very famous in Asian country region. Also, he's a big fan of Spaxus, right?
Yes.
And today he will talk about US guided drainage for biliary drainage and JGS with Spaxus and Spaxus. And he will do as a pre-recorded speech. Pradam Chai, please.
Yes, please. Thank you very much. Okay.
Hello, everyone. I'm glad to have a chance to join this lecture and conference today. I'd like to thank my moderator, Professor Chong Ho Moon, who is my close friend, and glad to meet Sandeep and Anthony. We are close friends and we have worked together for a long time. And I'd like to thank Taewung for supporting of this meeting. My topic today is a combination of EUS biliary drainage and EUS guided gastrojejunostomy in patients with combined biliary and duodenal obstruction. So if you look at this classification of combined duodenal and biliary obstruction, Nagi and his group has classified combined obstruction into 3 types: type 1, type 2, and type 3. And if you look at this diagram, it will be easier. In the type 1, the gastric outlet obstruction is located above the ampulla level, so-called supraampulla level. And the duodenal obstruction occurs in the same level with the ampulla, so-called ampulla level, and infraampulla level, respectively. This is meaningful for management of patients with double bile duct and duodenal obstruction. So, how have we treated those kind of patients? Nagai also collect several papers and use several methods to resolve problem of double obstruction of the bile duct and duodenal obstruction. And he also compare between endoscopy, EUS, and surgery. For malignant biliary obstruction, endoscopy could be ERCP, EUS can be EUS biliary drainage, surgery, hepaticojejunostomy, and gastric outlet obstruction, endoscopy is duodenal stenting. But EUS gastrojejunostomy at the time of his review was considered too invasive and information is not widely available. And surgery can resolve duodenal obstruction with the gastrojejunostomy. So look at the literature that have used endoscopy to resolve double obstruction. For biliary drainage, mostly PTBD, ERCP, and some for EUS. And stent type could be metal stent or plastic stent. And also for the problem method to resolve duodenal obstruction is duodenal stent, which technical success is very high. But practically, everyone know that to place both stents is very difficult, particularly if the duodenal obstruction occurs first in supraampulla level. We have to place duodenal stent first, and then we have to do ERCP through the mesh of duodenal stent, which is technically very difficult. So up to now, what is the rationale of combined US brain and gastrojejunostomy? If we look at the current choice that we have ERCP plus duodenal stent, which had been used, I think, a decade or more. It's technically difficult, like I discussed. And once we successfully place both stents, there might be problem of tumor ingrowth in both duodenal and biliary stent. Jejunostomy plus gastrojejunostomy in patients with advanced stage of cancer in this area, the ECOG score is so high. So actually life expectancy in this group of the patient is not that long. So even though surgical bypass is relatively non-invasive comparing with other major surgery like a pancreatectomy or Whipple operation, but in situation of advanced stage of the patient probably is invasive. So how about EUS brain and gastrojejunostomy combined together to resolve a problem of double obstruction? Actually, it's interesting idea, and Nagi also mentioned a little bit, but no information of this. And to date, no study so far that reported combination of both EUS drainage method to resolve of the double obstruction. So EUS BD versus ERCP in distal malignant biliary obstruction. Several papers have reported probably advantage of EUS brain over ERCP. And a recent systemic review published in EIO by Miller and his group has shown that from 3 randomized control trial, EUS brain has advantage of stent dysfunction, post-procedure pancreatitis and tumor ingrowth over ERCP. So in patients with double obstruction, which certainly the location of obstruction in the bile duct is distal bile duct obstruction, probably at this time look like EUS brain has some advantage over ERCP with stenting. So then, but EUS and ERCP is not an enemy together, but they are friends. Like in one of my study, which we just published in patients with complex hilar biliary obstruction, we compare between combination of ERCP and EUS, which so-called CRS combination of ERCP and EUS versus PTPD. We have found advantage of CRS over PTPD in terms of longer patency time and recurrent biliary obstruction. So how about EUS guided gastrojejunostomy? Today, there are 4 methods to do the EUS guided gastrojejunostomy. But to my idea, probably the safest one is using the balloon, EUS guided double balloon occlude gastrojejunostomy bypass or EPAS, which been invented by Takao Itoi and his group. And he and several of us, and his group do the multi-center trial to evaluate this EPAS balloon, and he found that in 20 patients with gastric outlet obstruction, if use the EPAS balloon to perform gastrojejunostomy is very safe, but certainly those procedures done by experts. So he pushed one balloon in and inflate balloon and at the farther end and the proximal end and fill in the water in the between, and then use lamps, hot lamp puncture in, and then create the gastrojejunostomy under EUS guidance. In my institute, we have been waiting for this EPAS balloon for years, but we still have patients coming to see us because of double obstruction. So then in our practice, so then we have compare and think about to offer EUS guided gastrojejunostomy to the patient. And if we look at this systemic review of EUS guided gastrojejunostomy versus duodenal stenting in patient with gastric outlet obstruction, the review have recruited 5 studies with 659 patients, and look like the technical successes of both methods were comparable. Clinical successes were also comparable, but re-intervention in EUS guided gastroenterostomy was just only 4%, but whereas in duodenal stenting is about 23.6%, which is significantly higher. And in terms of adverse event rate, they are comparable. So again, look at the endoscopic guidance, bypass of duodenal obstruction. Look like that EUS guided gastroenterostomy has a little bit of advantage over duodenal stenting in terms of re-intervention rates. So then, in this case, in our institute, we have a patient with supra-ampli duodenal obstruction and come to see us because of problem of both bile duct obstruction and duodenal obstruction. And this slide was created by my young colleague, Dr. Thanawat, who kindly do this video, and we already submitted to endoscopy and published around the end of this year. So we start with the ERCP procedure. We found the mass in the ampulla that we cannot do the ERCP. So then we switch the procedure to ES guided choledochoduodenostomy. We use the guide wire, and then we use the hot lumen approaching metal stent. In this case, we use the cold lumen approaching metal stent. In this case, we use cold Spaxus. And then you see that we puncture and we dilate the tract, and finally we deploy the cold Spaxus. But the patient still have duodenal obstruction. So then we did with the direct gastrojejunostomy method. We press the nasobury tube and fill in the water with methylene blue and puncture with the hot Spaxus and open the farther end and pull back, and then open the proximal end. And then we successfully had the gastrojejunostomy in place. So from this case, we can resolve problem of double duodenal and bile duct obstruction with the cold Spaxus and gastrojejunostomy with the hot Spaxus. So this is the information of the cold system. You see that they have the outer X-ray marker, they have the blue marker, and inner X-ray marker and yellow marker. So when you open the farther end, then you pull back the entire stent back until the farther open end hit to the duodenal wall, and then you pull the entire delivery system and stent back until you see the blue one, and then you gradually deploy everything. So then you have a successful deployment of the lamps for the gastrojejunostomy. So but for the hot system, you don't need the guide wire, you don't need the needle. You just go in with the electrocautery tip, and this one is a hot system or the hot Spaxus system created by Taewong company. So we have another case. In this case, the patient has malignant hilar biliary obstruction and with extensive invasion down to the duodenum and cause duodenal obstruction as well. So in this case, at the beginning, we tried to do ERCP, but we couldn't pass the scope into the duodenal bowel because of supra-ampli obstruction, and patient have malignant hilar biliary obstruction. So what we did, this is a 68-year-old man presented with jaundice, and the location of obstruction in the bile duct is in the hilar area. So then we try ERCP, but not possible because we cannot press duodenoscope into the duodenal bowel. So then we start with the gastrojejunostomy first. We press the nasobury catheter across the obstruction side, and then we fill the small bowel with the methylene blue diluted contrast, and then we puncture with the hot Spaxus, and we open the distal end and then proximal end, and we have successful gastrojejunostomy. And then this followed by the standard procedure of the hepatico gastrostomy. Use 19 gauge to puncture guide wire, and we use the taper tip catheter to dilate the tract, and then we press the GO ball hybrid stent, and then we have one hepatico gastrostomy stent across this one. So the patient went well after the procedure. the patient could eat well and also jaundice resolved. So then combining gastrojejunotomy and hepaticocolpostomy in patients with double duodenal obstruction and malignant high biliary obstruction if possible in this case. So my conclusion about double bile duct and duodenal obstruction is that to date, EUSBD plus EUS guided jejunostomy becomes an interesting option, but no outcome from large scale study yet. So at this time, we have tried few cases in our center, and I believe that in some center, they can start as well. And it's possible with the standard EUS breathing techniques and EUS guided gastrojejunostomy technique. And looking at the systemic review that I just showed you, EUS breathing has a little bit of advantage over ERCP in three main outcomes: patency time, tumor ingrowth, and lower rate of the post-procedure pancreatitis. And then looking at the systemic review that I just showed you, EUS guided gastrojejunostomy has lower re-intervention rate than duodenal stenting. So that's the reason why we like to know that combination of EUS breathing and gastrojejunostomy can be helpful or in patients with double obstruction. However, I like to remind you that both EUS breathing and EUS guided gastrojejunostomy is the advanced endoscopic techniques that you need to be properly trained from mentors to be good enough to do this procedure alone by yourself. And today, once again, I like to thank our sponsor, Taewon Company, that support this meeting. Thank you very much. Hello, everyone. I'm glad to have a chance to join this lecture and conference today. I like video finished already. Can you stop? Friend, and glad to meet Sandeep and Anthony. Dylan. Okay, all right. I finished my talk. Any questions from the audience? Moon, my friend. Can you hear me? Can you hear me? I cannot hear you.
Can you hear me?
Now I can hear you.
Okay, okay. There is some technical problems. It's always during webinar. Yeah. Very nice presentation, especially JGS. So you already shown about your procedure for JGS. As you know it, there are several different suggestions for the procedure for successful JGS. Like using a drainage tube or double balloon catheter by Dr. Itoe, you already mentioned. So which procedure do you recommend to be a safe and easy procedure for GJS?
Actually, like I said in my lecture, it would be good if I have e-pass balloon created by Takao, our friend, but it's not possible in Thailand and Southeast Asian countries at this time. So that's why we must start something to solve problem of our patient. So then we chose the direct puncture under small bowel filling with the methylene blue technique, and we felt that it's okay. And so far we have done, I think, almost 10 cases for EUS guided gastrojejunostomy, and all cases been successful very well without immediate and delay complication. So actually that's something that you can learn. And in my institute, at this time we use this technique.
Very nice. So you showed the whole procedure by only EUS for like intrahepatic and also intragastric. So how about comparing with interventional radiologist procedure, comparing with EUS guided procedure?
You mean the the interventional radiologist, they can do biliary drainage, but I don't think that they can do
bypass of the duodenum easily. The technique by interventional radiologists will be difficult or not possible, I think.
Okay, how would you like tell the advantages of US guided biliary drainage comparing with interventional radiologist biliary drainage?
Actually, I will talk a little bit, but not much because Anthony will cover this topic in the next topic. But for me, EUS guided biliary drainage is internal drainage. So in terms of quality of life, it's better than external drainage, clearly. And secondly, the actually also my data also published in Endoscopy beginning of this year also show that EUS guided internal biliary drainage has longer patency time than external biliary drainage by plastic PTBD2. Yeah. So this is my idea. So if we can, and I think if our patients know, I think that they prefer to have internal rather than external drainage.
Okay, very nice. And finally, what kind of metal stent do you use for US HGS, including diameter and length?
Or in my institute, we mostly use the hybrid stent, and most of the time we use the Geo ball, which is made by Taewon's company and invented, I think, by Professor Mark Giovannini. And we use 30-70. 30 is 30% of uncovered portion, and the length that we typically use is either 100 millimeter or 120 millimeter. We love to have longer portion of the stent inside the stomach rather than very short portion of the intragastric portion, because we feel that with these techniques, the recurrent HGS stent occlusion from food impaction is lower than shorter part of the intragastric stent. Yeah. Can you hear me well, John?
Very nice, very nice.
Yes.
Okay, thank you, Pradam Chai. If possible, please stay on our webinar for the final discussions with our speakers. Okay, thanks. And final speaker is Anthony from Hong Kong. He's very handsome, like on video, and very popular in social, having many good friends. He's not only an expert for even for very difficult procedures, and he's publishing many landmark papers about interventional US. So many young doctors are inspiring from him. Also, he's a leading Asian special study group. Today, he will talk about US guided drainage for pancreatic fluid collections and biliary drainage with specialists and heart specialists. Anthony, now you are on the stage.
So, hello, thank you very much, Professor Moon, for your very nice and kind introduction. So, are you hearing me well?
Yeah, very nice, very nice.
So, the title of my talk will be on US biliary and gallbladder drainage with the Spaxus. So, thank you very much for your kind introduction. These are my disclosures. So just now, both Sandeep and Pradam Chai have showed us a very nice overview in using Spaxus for drainage of the pancreatic fluid collections, as well as the bile duct, as well as the gastroenterostomy. So, and for me, I'm going to highlight the area in the biliary tract, as well as the gallbladder. So it really gives us a great idea in terms of all these different types of drainage, in that actually we are celebrating a festival in US guided anastomosis. So from the bile duct to HGS, to pancreatic gastrostomy, to gallbladder, to cholecystoduodenostomy, and finally to gastroenterostomy. So we are almost like surgeons performing all these different kind of anastomosis. And also with performance of these procedures, we are really making a difference to patients' lives. So this is a very exciting time for us to be living in as an endosonographer. So as Sandeep has showed us, there are various types of US specific metal stents. For us, we would consider the Axios and Spaxus as lumen opposing, whereas the Nagi, the lumen opposing force is a bit low. So if you are draining non-adherent organs, like the gallbladder or performing gastroenterostomy, perhaps Nagi stent may not be a very good choice. Also, for these stents, there are some characteristic designs. These stents have bi-flanged ends. The diameter is large, so both the Spaxus and the Axios previously were 15 and 16, but now can be up to 2 centimeters. The distance is between the flanges. Axios is 1 centimeter, and recently a 1.5 centimeter version has been produced. For Spaxus, although it seems the distance is shorter between the flanges, when the flanges are completely approximated, it's 8 millimeters between the two flanges. But if there's a bigger distance between the two flanges, actually the flange don't need to go all the way to 7 millimeters. So if you have an organ that is very far away from the stomach or the duodenum, if you deploy the Spaxus, actually it's safer because the flanges wouldn't need to compress it so tightly. So this diagram is from Professor Moon's paper. It shows you that the two flanges of the Spaxus actually responds to differently to the distance between the tissue. If there are more tissue in between, then it does not compress so much. But if there's less tissue in between, it can compress a bit more. So it will adjust to the distance between the two lumens. So as we know, Spaxus comes in different sizes, 8, 10, 16. And as the diameter of the Spaxus stent increases, the flange size also increases. So for the gallbladder, usually we can use a 10 or 16. For the bile duct, usually an 8. 10 might be a little big as well. And for the bile duct, we need to be careful because the design of the Spaxus stent is that the flange will fold back on itself. So if the bile duct is not so dilated, it may not have enough space for the stent to fold back on itself. So when you perform CDS, you need to be aware that of these anatomical and design restrictions. So this is a very nice video from Professor Moon. You can see a very dilated bile duct, almost 2 centimeters or even more. So the first step, this time it was still the cold Spaxus. So puncture, guide wire, dilation with a cystotome, followed by a balloon, and also stent insertion. So as you can see, we need to have a bigger space for the flange to fold back on itself. And thereafter, the stent is deployed under endoscopic guidance. So on fluoroscopy, this looks like this. You puncture with needle, guide wire, dilation with the cystotome, insertion of the stent, wiggle it a little bit to allow complete opening of the flange, deploy the proximal flange under within the channel or under endoscopic guidance. And with such a large diameter stent, certainly we can perform a cholangioscopy, which is one of Professor Moon's favorite procedures. We can have an access to the bile duct or the pancreatic head. So right here, you can see it is a cholangioscopy. The stent was removed to allow easier manipulation for the endoscope. Once the endoscope is inside the bile duct, you can either go up into the bile duct, upwards, and you can see stones. Or you can move downwards to see the tumor within the pancreatic head. So as Taiwan continue to develop their stents, now we have the hot Spaxus. So Sandeep has showed us the procedure of hot Spaxus draining the pancreatic fluid collections. We also have some experience on performing the procedure on gallbladders. So far the burning capability of the delivery system is very good. We are happy to perform direct puncture of either water collections or the gallbladder with this system. Recently, we have published the long-term outcomes of CDS and gallbladder drainage with the Spaxus. Both Praram Chai as well as Sandeep and Professor Moon are part of our co-investigators, and I thank them very much in their continued support of during this study. So for CDS, we had 26 patients. Clinical success were 88%. None of the patients had bleeding within 30 days. Some patients had misdeployment. On terms of long-term adverse events, since these stents are placed in the longer term, again, there are no patients with bleeding and no patients with cholangitis. In terms of the gallbladder drainage, 27 patients had gallbladder drainage. Technical and clinical success, again, 88.9%. Significantly more patients had larger diameter stents. That's probably because of our preference in placing larger stents for gallstones removal. And again, in the longer term, we don't see the issues of bleeding and bleeding in the gallbladder drainage group. So as we know, with the use of a lumen opposing stent that has a very high lumen opposing force, initially there were a lot of reports of bleeding, especially if the stents are placed for the longer term. So one of the speculations is that a stent with a high lumen opposing force may be too traumatic. In this study, we were trying to see whether the Spaxus would have similar outcomes. So happy to say that we don't see much stent-induced issues in this long-term study. In terms of the future of USBD, I think apart from performing procedures as per usual, in terms of USBD drainage, we really need to see expanded indications. And also with all these new devices, apart from they are fun toys for us to play with, we really need to improve the safety of the USBD procedure. So the conventional indication for USBD, as we know, include usually failed ERCP. But as we are all very skilled ERCPists, so actually we know that the percentage of patients with failed ERCP are quite low. So that's why we are also looking at expanded indications. An area that is very interesting for endoscopists is whether USBD can replace ERCP. So the rationale is that in USBD, we can avoid placing the SAMs across the tumor. This may increase the stent patency, reduce procedural time, and there's no risk of pancreatitis. Of course, USBD requires technical expertise. There's a risk of severe events, and the stent is often expensive. So this year, we are very happy because our randomized trial comparing US CDS versus ERCP and SAMS, named the DRAMBO, not RAMBO, but DRAMBO, Drainage for Malignant Biliary Obstruction trial, has been accepted as a ASGE plenary in this year's DDW. So for you to have a sneak peek in the results. So the last patient was only recruited in January this year, so we are still following up the patients. But in terms of the short-term outcomes, we have noted that the technical success rate of CDS was significantly higher in the CDS group, 94% versus 70%. Many patients in the ERCP group had a degree of duodenal obstruction, and also the tumor in the head of pancreas actually makes it difficult for cannulation. In terms of procedural time, we also saw a significantly shorter procedure time in the CDS group, averaging 15 minutes. In terms of the 30-day adverse events and mortality, there were no significant difference. In terms of the 1 year stent dysfunction rate, we haven't seen any difference, but mind you, most of the patients are still being followed up. But we are seeing some difference in the rate of tumor ingrowth. So hopefully with time, we can see more difference and support and provide more advantage to the US CDS group. In the CDS arm, the reasons for stent dysfunction included other causes like partial migration, foot impaction, impingement of opposite wall. So although we can reduce the number of tumor ingrowth, but maybe CDS also have other issues, particularly if we use a short lumen opposite stent. Another significant development in the USBD procedures are these single-step devices. So these are very important because with a hot Spaxus, we really reduce the number of all these different steps into one step. So the importance is that it can reduce the difficulty of the procedure, reduce the risk of bowel-leak and adverse events, shorten procedure time, and also decrease the learning curve. So for our younger generations, they will be much happier to learn these procedures, because for us, we had a very long learning curve, and we had to borrow all these instruments from ERCP and struggle a lot in the initial developmental phase. But with all these year-specific devices, it becomes a very enjoyable to perform an USBD procedure. So apart from lumen opposing stents, happy to show here that the idea is also being applied to hepatogastrostomy stents. So I think Professor Moon will tell us more about the new MG HGS or the HGS geoball and the HGS Spaxus stent. Certainly we'll be very excited to see your videos. So I'm going to touch a little bit about gallbladder drainage. This is my very prime area of research. So in the past, I would say this is mainly for non-operative candidates. For me, it's a logical step, because if you look at the development of ERCP, we went from surgical T-tube to percutaneous drainage to ERCP. Similarly, the same idea can be applied to gallbladder. So we are really looking at gallbladder drainage via the duodenum or the stomach. And current indications include acute cholecystitis in patients who are at very high risk for cholecystectomy, patients on long-term percutaneous cholecystostomy, patients with malignant biliary obstruction with failed ERCP, as well as failed USBD. So high-risk patients are defined by these criteria. Basically, if the surgeon doesn't want to operate, then you can consider offering them USBD. For us, for our study, really puts the USGBD into the scope of the management of acute cholecystitis. So if you look at surgical candidates, according to the TG18 guidelines, it's still laparoscopic cholecystectomy. marginal candidates, if you follow the chocolate trial, which compared percutaneous versus lab chole, it is again favoring lab chole. And with our study in DRAG's study published in Gut, it really favors US GBD. So our DRAG study compared percutaneous drainage versus US gallbladder drainage in patients that are at very high risk for cholecystectomy. So in our study, we had a very convincing outcomes. In terms of the 1-year adverse events, it was significantly less in the gallbladder drainage group, 25% versus 77%. We also had significantly less recurrent acute cholecystitis. Only 1 patient in the GBD group, but 8 patients in the percutaneous group. In terms of re-interventions after 30 days, unplanned admissions, 30-day adverse events, again, all favoring US GBD group. So in centers where US drainage expertise are available, certainly this group of patients would benefit greatly from US GBD. But one of the main drawbacks of GBD, especially when I was performing my randomized trial, was the cost. So we actually did a cost-effective analysis comparing US GBD versus PD GBD. So the pros of US GBD, we can reduce re-intervention, reduce readmission, but the initial procedural cost was very expensive, mainly due to the cost of the stent. For PD GBD, procedural cost was cheap, but recurrent admission, re-intervention, all that were expensive. So we did a cost-effective analysis comparing the 2 procedures. At the end, we found out the total average cost of US GBD was still much higher than PD GBD group. This is mainly due to the cost of the stent, but US GBD reduced the cost of re-intervention and also unplanned admission. So perhaps with this cheaper alternative, perhaps Taiwan can think of providing a cheaping alternative, which they are already providing. Perhaps the cost effective between US GBD versus PD GBD can be smaller. This is another multi-center registry on US gallbladder drainage. This was published in EIO. We compared the 3 different types of stents, Axio, Spaxus, and other stents. We found that basically the clinical outcome were not different between the 3 types of stents, but actually it is the endoscopist experience. If they had less than 25 procedures, they had more issues in terms of unplanned procedure events, lower clinical success, and as well as mortality. And actually with this study, we concluded that the learning curve of the procedure is around 25 procedures. In this last part, I also want to discuss on US gallbladder drainage as an alternative to biliary drainage, especially in patients with ERCP failure. So this idea is similar to the idea of a surgical cholecystogenostomy, but the effectiveness of gallbladder drainage for the bile duct depends on the patency of the cystic duct, and only about 50% of the patient has a patent cystic duct. And if you think of using the gallbladder for draining the bile duct in malignant obstruction, recurrent biliary obstruction is quite high. So really, for me, if US GBD is used for draining the bile duct, the patient needs to have a ERCP failure as well as US BD failure. So the chances is, the indication is quite low. But nevertheless, a good friend from Italy just presented this oral abstract in ESGE, which included 14 Italian centers, a very high technical and clinical success rate, and adverse events was only encountered in 5 patients, mostly of mild to moderate degree. This is a very exciting area. How about surgical candidates? So just now I was just discussing USGBD for non-surgical candidates. Many of you know that I'm a surgeon. So one of the idea is to see whether USGBD can be comparable to lab chole. So this was published last year in GIE. I performed a propensity score analysis comparing USGBD versus lab chole. When this paper came out, it made a lot of people very excited because as you can see, amongst all these different parameters, actually none of them were significantly different. So I'm not trying to say the two procedures are the same. I think lab chole is still the gold standard. But I think in some patients, if we carefully select them, actually the risk of recurrent cholecystitis, recurrent biliary events can be comparable to lab chole. And for lab chole, in patients, if it is performed in patients with acute cholecystitis, actually sometimes around 20 to 30% of the patient would require conversion to an open cholecystectomy. And there's also an increased risk of bowel injury. So there can be severe problems with lab chole as well. So with this study, I'm just saying in some patients, maybe USGBD is an option for surgical candidates as well. So in conclusion, USBD and GBD with Spaxus is a highly effective treatment procedure. There are some definite benefits over percutaneous drainage, and also these procedures are challenging outcomes in conventional modalities as well. And the procedure can also act as a portal for further intervention in the bile duct and the gallbladder. So thank you for your attention.
Thank you, Anthony. Can you hear me?
Yes.
Very nice presentation. Very impressive as always.
Thank you very much.
So especially very impressive data about comparing EUS CDS and ERCP guided biliary drainage for distal CBD malignant obstruction. Did you include resectable case also, or just only for non-resectable case?
Just unresectable.
Unresectable case.
Unresectable, yes.
Okay. And what's happening about tumor ingrowth in the group of EUS CDS? Do you have any suggested mechanisms for the kind of very unusual? What do you think about that?
Yeah, actually, these patients have a very advanced disease. So for those who can live long, sometimes the D1 area, they can have tumor infiltration. So because CDS is placed in the D1 area, sometimes also the tumor can obstruct the opening either in the bile duct area or the D1 area. So it's uncommon, but it did happen.
Okay, do you mind any differences intrinsic bile duct cancer or comparing with pancreatic cancer for the EUS guided drainage?
Yeah, most of the patients had pancreatic cancer, so I haven't done any subgroup analysis comparing cholangio versus pancreatic. But as I mentioned, we are still following up some of these patients. So by the time we finish follow-up, we can do a subgroup analysis.
Okay, there is some questions from the audience. Okay. So do you still use the plastic stent for EUS guided drainage?
Plastic stents, yes, maybe for pure fluid containing PFCs. I'll use plastic stents. How about you, Sandeep? Do you still use plastic stent for PFCs sometimes?
Yes, I do. Yeah, I do for pseudocyst, like in chronic pancreatitis or in wands with very minimal debris.
Madam Chai, how about you?
I mean, I do about the same with Sandeep in a PRO pseudocyst and not a large pseudocyst. We still use plastic stent to save money for our patients.
Well, I think for us, a lot of times cost is a concern in patients, particular if plastic stents can do the job, I guess why not? But I think recent in the coming DDW, the Dutch pancreatitis group actually will have a randomized trial comparing plastic versus metal in ward-off necrosis, and actually they have shown no difference between the two groups. So it'll be interesting to see the results and how it alters the practice when the study comes out.
How about US guided gallbladder drainage for plastic stent? Do you use still?
Oh no, I don't use plastic for gallbladder drainage.
Okay, next question. Is there any US guided biliary drainage standardization protocol?
Can you repeat that? Sorry.
Is there any standardization protocol for US guided biliary drainage to reduce adverse event and increasing effectiveness?
So yes, so we actually, Sandeep and I, we both belong to the, and Professor Moon, and all of us here, we belong to the Asian US group. So we actually published a guideline on US guided interventional procedures. So that guideline has included all the pre-procedural, procedural, and post-procedural management. So yes, with that guideline, we are trying to standardize the procedure, and I think it's important to standardize because it can reduce the risk of complications.
Thank you. And do you think the direct penetration using hot delivery system without guide wire by US FNA needle can be the standard procedure for US guide drainage with lamps?
For me, it really, I will look at the target organ. So if I have a big, nice target organ, then I would perform a direct puncture. For the bile ducts, most of the time it's not super dilated. So many of our patients only have a mildly dilated bile duct, 12, 13 millimeters. In those patients, I would prefer to puncture with a needle followed by a guide wire. How about your practice, Moon? Sandeep?
I totally agree with you. Basically, I'm using FNA needle and guide wire. So last question from the audience. How do you manage the patient with misdeployment of stent in US guided gallbladder drainage? Your tips to avoid misdeployment also?
So I think if you are just starting to learn this procedure, then I suggest you to use the conventional method. Even if you are using the hot Spaxus, put in a needle first and a guide wire, and then deploy your stent. If you misdeploy the stent, you still have the wire in the gallbladder, then you can still perform a stent-in-stent procedure to salvage the procedure. And also it really depends on what you mean by misdeployment. So misdeployment of the distal flange or the proximal flange, the management is slightly different. So if you misdeploy the distal flange, actually you can resheath the Spaxus and try to reinsert everything in the proper position and redeploy. If you completely misdeploy the proximal flange and push the entire stent into the gallbladder, then you will need to perform a stent-in-stent procedure.
Very nice. So I would like to introduce some development of DTS Spaxus at this chance. Let me show a Spaxus 2. This is version 2, having a shorter length and a smaller diameter of anchoring flange like this, and its own hot 9 French delivery system. It makes easier puncture. It should be a smaller diameter can be the better. So this video shows US guided gallbladder drainage using a 10 millimeter hot Spaxus 2 in 9 French delivery system. As I shown in the video, it's very easy to puncturing, and inside the gallbladder, and stent is deployed easily. And this is for 8mm hot spacious 2 in 9 French delivery system, present to Anthony. So I think you are waiting that kind of new one. It's 8mm diameter, and the flange is smaller than comparing spacious 1. It's 18mm in diameter, and the length of stent is 12mm. This video shows US guided CDS using 8mm of spacious 2 in hot 9 French delivery system. And like this video, very easy puncturing inside the bile duct. So it reducing the diameter of anchoring flange. So it's much less to contact on bile duct, even after complete deployment. And this is an endoscopic view. And now also we are developing a new bipolar electrocautery enhanced delivery system to reducing tissue damage by electrocautery, or doing without a return electrode plate like this. And hepatogastroscopy is creation of new fistula between upper stomach and left intrahepatic duct. And there is some very critical issues like a fatal stent migration after stenting. So we developed a Spaxus MG. Anthony already mentioned about this stent during his speech. And it has a 20mm proximal anchoring flange to complete folding back to prevention of migration and to access port to bile duct through here. And it has very distinct radiopaque marker, like distal radiopaque marker for uncovered intrahepatic portion. It's on 15mm. And also it has a proximal radiopaque marker for proximal stomach segment. It has 20mm on here. And diameter is 2, 8, and 10. And the length is 6, 8, and 10. And it's on 8.5 French delivery system. So you can see the nicely or fully deployed proximal flange on this photo. Let me show just the case after puncturing on dilated intrahepatic duct. And after dilatation, stent is inserting. You can see the nicely deployed distal radiopaque marker. It's on uncovered portion. It should be on intrahepatic duct segment. And stent is deployed. And you can see the nicely deployed proximal radiopaque marker in 20mm in diameter. So it should be on stomach side. So this is endoscopic view. With this stent, now I'm doing a very comfortable and very relaxing procedure, EOS guided HGS. So we can see all markers for intrahepatic side and intragastric side. And we don't need a longer stent length on stomach. And additionally, one of my hobby, and this is after stenting, well, maybe 1 week later, 5mm thin ultra slim scope is inserting through the HGS for a future interventional procedure. This is endoscopic view. You can see that this stent can make a short length of intragastric segment, and slim version of endoscopy is inserting easily inside the bile duct through the stent. Now you can see the bifurcation here and proximal bile duct here. So you can make the future intervention using that kind of stent. So now I would like to have a time for discussion for some important issues with our speakers. So I would like to ask all speakers. As you know, Spaxus is on a conventional delivery system, but Axio is on a specialized delivery system. Could you comment on the technical differences of Spaxus comparing with Axio during the procedure on delivery system? Sandy, you should be the first.
Axios has a very different delivery design, which has steps 1, 2, and 3, and 4. They are not intuitive. What I mean is, conventionally, we have been using esophageal stent or an enteral stent or a colonic stent, where the stent is inside a sheath, and when we pull the sheath after positioning the assembly, the stent is accurately in same position. Axios has a very good design, but this is not very intuitive, the mechanisms. And one has to learn those steps. And once you get over those steps after, say, 10 or 15 cases, then those steps make things easy for you. So much so that you don't need a fluoroscopy for at least draining a pancreatic fluid collection. Jong, you're mute.
Sorry. Pradam Chai?
Yeah, to me, I think clearly Axios and Spaxus, they have two different deployment techniques. Axios is step by step, 1, 2, 3, 4, and Spaxus as well. They also have their difference, but those two techniques can be learned. And then if you learn properly, I think it's fine for both sides. But for Spaxus, always some development. There are always some change of the deployment system from the longer portion of the stent, probably in the future, shorter and shorter. So we just keep learning. For me, and also for experienced hand, I think that they feel no difference. But in beginners, before you start, I would recommend you to know the device very well and the deployment system or post system very well before you start one by one. And you should be familiar with the one that you're going to use. And probably, if you repetitively use that for a few times before you switch to other companies, that might be helpful for you. This is my idea.
Great. Anthony?
For me, I agree with what Sandeep says. You need to learn how to deploy the Axio stent. For the Spaxus, it's the conventional system, so it's easy for anyone to deal with it. The pros of Axio deployment system is that the endoscopist, you can do everything yourself. So if you don't have a skilled person around you, you can deploy the stent by yourself and you have full control. The deployment system also carries two different important differences. So the Axio system is a backward deployment system, whereas the Spaxus is a forward deployment. So with the Spaxus, like all conventional baby stent, if the endoscopists don't move, you open the stent will push inside. But with Axios, if you deploy the stent, actually it will open backwards. So meaning even if the tip is in the bile duct, if you open the stent backwards, it will be a chance of the stent being outside the lumen. So this is more important than who opens the stent. So for Axios, if you have a very tight area, sometimes you cannot push the delivery system deeply, then you may run into problems because the stent is backward deploying. So actually the tip of the delivery system is in the organ, but the stent is outside. So this is the more important idea. But with the forward deploying system, because you deploy the stent inside, so sometimes if you can't insert the delivery system deeply, but you know the stent is going to go inside, so you can still get away with a not so deeply inserted delivery system. So it's pros and cons.
Very nice point. Yeah, Sandeep, please.
So there's, apart from what Anthony has said, there's a little difference also when Axios, if we misdeploy the first part, we cannot recapture. Whereas in Spaxus and Nagi, we can actually recapture and do it again. So we don't waste a stent. And the difference also can be correlated with a car. You have the car with the gear system is the conventional Nagi and Spaxus, whereas the automatic car is the Axios. So one has to learn to drive both the cars and then win a race.
Very nice talk. Okay, let's move for next questions. So one of the issues of Axios is a possible adverse event like delayed bleeding and buried stent syndrome. So how about your experiences of Spaxus regarding the kind of adverse event? Now it's turned from Anthony. It should be fair.
To me first?
Yeah, it should be fair.
Okay. Spaxus Stent, have I run into problems? I have. So as I mentioned, in about because the Spaxus needs to fall back on itself. So in 1 or 2 patients, when we use it for CDS, the buttock is too small, and actually the stent cannot fall back on itself. So this is one of the issues that I had. Bleeding, I had 1 patient with bleeding, but that patient had gallbladder drainage, and the patient was on apixaban, so oral anticoagulant, so has a risk factor for bleeding. And in that patient, actually, was after we removed the stent and changed it to a double pigtail, the bleeding really stopped.
Great. And Paramchai?
Always, I think when you do the US guided drainage in from other organs or with complications when you are in the learning curve. For me, with the Spaxus that I had, I mean, one is we deployed the proximal end into the abdomen incidentally. At the very beginning period, we didn't know about the endoscopic techniques at this time. And what we saw, we did the surgical hepaticogastrostomy by convert to the operation. And then we push the proximal end of the stent, the gastric side, back into the hole. And then it became the first surgical hepaticogastrostomy, and then we can change the problem of that problem. The other problem, which is maybe more common, like Sandeep said in his lecture, incidentally migration of the entire stent into the wand or into the pseudocyst at the beginning. And then for Spaxus, what we do, we use another Spaxus and then deploy and then keep the track open. And then we go in and we brought the O1 that migrate out. And then and in some times when we did several times of the direct endoscopic necrosectomy, so the Spaxus, lamb Spaxus come with the balloon and debris, like Sandeep showed in his slide, back into the stomach. So what we did, we brought it out and we rewrote into the delivery system of the Spaxus, which we can do in Thailand. So then, and we redo it again. But now we learn from Sandeep today that actually there's no need. Just push it back into the scope and push it back into the gastroscope. And we just, this is probably 2 or 3 days ago, the technique that you showed, Sandeep. Yeah, that's as I remember at this time. Yeah.
Okay, Sandeep.
So migration is the commonest complication that we have faced, but most migrations also now we're able to manage. Bleed, yes, but more actually peculiarly with, not with Nagi stent. If you feel all these stents in hand, Nagi is very soft stent. It's very malleable, whereas Spaxus and Axios are little rough in the inner end. And that causes when it hits the back wall of the cyst, as it collapses, it rubs that and causes bleeding from either the healing granulation tissue or the big vessel in there. And I had 1 or 2 episodes of a major bleed from the splenic artery, which needed to be embolized by IR people. That's the main adverse event that I faced.
Very nice. And
Axios I mainly use for gastrojejunostomy, and I save money of the patient for GJ, which is left in a malignant outlet obstruction.
okay, very nice. And Anthony already touched about this issue in his speech. And as you know, he basically Axio shows like a fixed apposition regardless of the wall thickness. But the Spaxus can make some, I want to call it accommodable apposition according to the wall thickness for anastomosis. Do you think it can be reducing some adverse event for as a lamps? Sandeep, it's your turn now.
I don't know. For Axios, I'm not sure. But I'm just worried if Spaxus folds on itself and if the wall is thick originally of the stomach and the pseudocyst or whatever the target organ, does it cause any pressure necrosis when the folds on itself and wall is thicker than say 7 millimeters? I'm asking a question then answering your question.
Yes, it's true. It's true. 7 millimeter. Yeah. Okay. And
I don't think there are any. I haven't experienced any patient with pressure necrosis. So the force of the holding back of the flanges are actually not that high. So that's why Professor Moon said that it's more accommodating.
so, Anthony, what do you think about this concept? So it can reduce some adverse event as a limb?
Well, I think it depends on what you are trying to drain, right? So if you are looking at a PFC, sometimes it's a very thick tissue, and actually you don't need such a strong lumen opposing force. So I think it's a good thing. I think for some non-adherent organ, for example, what Sandeep said in a GJ, you want a stronger stent to keep the two organs together. In those situations, maybe you want a stronger lumen opposing force. But having said that, I am aware that people are performing GJ with the Spaxus as well. But I haven't had any experience, so I'm not sure if it works well or not.
Very nice. Pradam Chai, do you have any opinion?
Actually, I think it depends on organ and techniques. And then for the choledochordinostomy, for the